Here, this is the backlog. You know, this 1 hour I spent for my last lectures left over. So guys, we are looking at a sagittal view. What you got your attendance now? So we are looking at a lateral view, sagittal section, and there we have these landmarks, symphysis pubis, the main part. This thing, if it persists, we call it urethra. This is the urinary bladder. This is the urethra. Can you see this dark brown thing? Normally it has to be closed. If it persists, then there are conditions. And this is the wall of the urinary bladder, mucosa, and then this is the whole length of the urethra. Now what happens? This part, the part of the urethra which passes through this muscle layer, this muscle has a name for that. This is not perineal body, is a place where so many muscles have crossover. So this muscle has a name. And now there is a prostate gland we are looking at, and this is the seminal vesicles on its back. So now this muscle makes my sphincter urethra. This muscle has a name. And when this urethra passes through this muscle, sphincter urethra muscle, that part of the urethra which passes through this muscle, we call it membranous part of the urethra. And the part of the urethra which passes through the prostate, we call it prostatic urethra. Okay? And then we have the penile urethra, it has different parts. We'll be talking about those. There are different ways of classifying urethra. We have anterior urethra and posterior urethra. We have prostatic urethra, membranous urethra, penile urethra, bulbar urethra, and then it has external meatus, internal meatus, and then there is another place, we call it navicular fossa. Guys, I was asking yesterday, none of you are answering that. So now, corpora spongiosum surrounding the immediate layer. And then in front we have corpora cavernosum. These are erectile tissues which are filled with the blood at the time of erection. So now these muscles, bulbospongiosis is down, and then this fascia, it has a name, Buck's fascia. This is the same. We have Colles fascia, we call it Colles fascia at certain places. But now here we call it Buck's fascia, the one who surrounds. Now, can you see this suspensory ligament? Safe. Close it. See it here. So now this is the levator ani muscle, and it holds everything. And all these organs has been suspended by this levator ani and different parts of the levator ani. So now you can see that around the rectum, we have so many sphincters. The body's most strongest sphincter is surrounding my anus. The sphincter which surrounds the rectum, the sphincter which surrounds the anus is the most strongest sphincter of the body. And if someone loses that sphincter, it means a big damage has occurred. A big damage has gone. That's why you have seen, you might have noticed, in the extreme of ages, older people, they lost control on their feces also. And this is the indication that there is a big issue with there is something demyelination occurring in a big way across the spinal cord, because this nervation is very, very important. And one has to be very careful for these kind of infos. Are we clear? So there are you looking at, there are 4 sphincters who surround the anal canal. 3 external, 1 internal. I'm sure you must have learned this concept. You have done GR. Yes. Do you know this? So now this is my endopelvic fascia, and then I have the peritoneum. And this is our peritoneum. It covers, these are the relations of the peritoneum. Abdul Majid, long time no see. So that is covering these organs. And now this is all around it. We are not talking about these layers. Campers and Scarpa we talk about it with anterior abdominal wall. Am I right? Somebody must have explained to you. Campers and Scarpa fascia. So this same thing, it changes its name. Here we call it Colles fascia. When it comes around the penis, we call it Buck's fascia. Same fascia, only transposition is different. Here it called Dartus fascia. So same thing, when it moves, it changes its names. This slide is important for understanding different kind of injuries, why and this happens. So now, So now these are the venous plexus that talk about those. Vesical venous plexus and prostatic venous plexus. Now this slide, we did it before. So I'm not going in its details. Now, this is the prostate gland inside. You can see that this blue thing is the urethra which pass through it. And can you see there are numerous glands, numerous ducts. They are connected with the glands. Those are the prostatic glands. And these ducts, and there are numerous openings inside which are not visible. I only mentioned you about these three openings. And these three openings are located in a heave. And that heave is given a name. That area is given a name. Do you have any idea what is the name given to that? I'm sure it has been explained to you in the lab. Verumontanum. That's a clinical term. And anatomists, they call it colliculus seminalis. Colliculus. This is the name for anatomists, but clinician they call it verumontanum. Now, you said about verumontanum. Allah, tell me about what is the significance of verumontanum and why we need to know about verumontanum. Yes.
It's an important landmark when you're inspecting the urethra.
Really?
Yes.
If this is not there, you cannot inspect the urethra?
No, it's an important landmark.
Like if I put something here, it will be obstructing your view or it will be making things clearer to you? Maz, I can see you. Don't disturb Ali. Ahmad want to say something. Yes, Ahmad.
It's a landmark that shows that we entered the external anesthesia.
Okay, this is your perception. Maz, what do you want to say?
It's a landmark after which if there is some kind of injury, the person will become impotent.
No. Never. Aswad, you are playing with your mobile since morning. Yes. Wazi, why you came? Alas,
Continence, not incontinence.
you are done.
Continence you can.
Yes, Ali.
It's a landmark, but when you go behind it, the person become incontinent. Like, he cannot.
Your answer is okay, but it will not give you any marks. It will rather cut your mark. You know the answer, but you don't know how to place it. Any other person? Anyone else? Yes, my dear. Yes, you.
Because if you went beyond this point, you will be cutting the external urethra.
You're not sure. What's your name?
Saad.
Guys, give a big hand to Ahmad and Saad. Ahmad was sure, Saad was not sure, but his answer was right. Ali was very close. Ali went other way around. So, this, first let me show you that. Yes, this is the one. This is verumontanum. This is how it looked like. This is a real picture. It's not a drawing. And now, this place, endoscopically, we don't see outside. Our scope is in and we are looking inside. So at this point, this is a reference point where we have the location of external urethral sphincter. And if we cut beyond, if we cut away from this place towards me, we are for sure damaging the external sphincter. And if we cut someone's external sphincter, means that person will become incontinent. Now this person will not have any control on his urination. So the moment the urine is filled in the bladder, because now you might have a question, you might ask me, you said that I told you guys that male has two sphincters.
Yes.
Male has two sphincters. So why I'm saying if this is cut, now the person will become incontinent, because in the male, when we are doing resections, we are doing resection for the prostate. And when we are resecting for the prostate, we are already damaging the internal sphincter of this patient. Now he has to live only with his external sphincter. So you have to damage, you have to chop away the internal sphincter for the sake of treatment. And external sphincter, you are damaging because of your ignorance, because you're less learning, your poor understanding of the subject. So if you damage two, one you have to and one you did it by mistake. So means your patient become incontinent. And when someone become incontinent, the one who was not able to make urine, the one who was not able to pass urine, now he has no control of the urine. So it's a big type of litigation and you can be in big trouble. So one should be knowing this is one of the reference point where everybody should be clear about if you are putting an endoscope in, that at this level, behind that is an area where external sphincter ends. So if I cut at that part, I'll directly be damaging the external sphincter, and that is connected with serious consequences.
So the external sphincter will be distally to the verumontanum?
Yeah, exactly. The verumontanum is a landmark, is a reference point.
So proximal to it, it will be fine.
Proximal to it you can do, but distal to it, you are around 80% you are cutting it. I'm not saying 100%, 80% approx. Are we clear about this, Ali? Now can you rephrase your answer? Your answer was fine, only you went other way around. You are very close. You deserve half of the claps, not full. Thank you guys. So now, going back, we were here, and so we can see that there are so many openings. These two openings belong to the ejaculatory ducts. So they are pouring the semen. This is connecting the prostatic utricle. These are so many prostatic glands, and they are pouring their secretions into the urethra, like other glands. So they are responsible because urethra has to be kept moist. Urine, how much time you pass urine in a day? Think.
3 times.
3 times, 4 times, 6 times maximum. But urethra has to be moist. If it's not moist, if it becomes dry,
Maybe
it's a problem. Infection can start occurring. So these glands are continuously pouring, but not obviously these. There are other urethral glands. These glands are responsible for generating the stuff which is needed for well-being of sperms. So fructose and other things has been liberated from these, and these are the ducts of those glands. Going further, you can see on a section, this is the rectum, and this is how the urethra is sandwiched, is clasped between the substance of the prostate gland, and you can see these are the prostatic venous plexuses. And prostate is surrounded by layers of capsule. Prostate is surrounded by capsules, and I have skipped that slide which I should show you. I must not skip that. Mashwar, I know.
It's faster from the keyboard.
it's easier from the keyboard.
Because this slide is that important. Why I'm going to that, Mashwar? Yes. Guys, this slide. These words. We know about it? Yes, this is very important. Prostate, please swallow it. Prostate is partially glandular and fibromuscular structure. Histologically, whatsoever you learn, it's fine. But this word, if somebody asks you what prostate is made up of, this answer should be there. This is the key. These are key words. Partially glandular, partially fibromuscular organ. So this gland has glands, muscles, and fibers. Is made up of these. Is present under the urinary bladder. This gland is penetrated by urethra, proximal part of the urethra, the beginning of the urethra. It's normally like a walnut. I'm sure people have seen walnut. Walnut not without shell, with the shell. Its length is less than its breadth. So it's more broad. So this is the exact about its dimensions. In female homologue, we talk about gland of Skinny. And prostate provides 30% of the volume to the seminal fluid. Right? So this we need to know. So the capsules of the prostate, like we talk about coverings of the kidney. This is another very, very important concept. Capsule of the prostate, it's surrounded by a true layer and a false layer. And between these two layers, we have the presence of the venous plexus. And that's important. Are we clear? So between these two capsule layers, we have the prostatic plexus of the veins. Are we good? Now I'm skipping from here because I don't want to go to again and again. We talked up till this part. So we talk about that. Let's proceed. Now this is these slides, guys. These slides are main basis of understanding of prostate. How really it affects us. What are its different? Look, the older books and older people will talk about lobes of the prostate. But the current and the practice talks about the zones of the prostate. Even your books of anatomy, good books of anatomy, they say up till the 20th week of intrauterine life, lobes are there. Beyond, lobes are no more identifiable. And now we are left with the zones of the prostate. And these zones are very important. So prostate is basically made up of 4 zones. And this is my urethra, this tube. And these are my seminal vesicles. And these are the ejaculatory ducts. And you can see that they are entering into the prostatic part of the urethra. And the prostate gland is surrounded by this rounded core. This core is given the name of transitional zone. So if there is a pathology in the transitional zone, if there is a problem with the transitional zone, it will cause compression on this tube which goes through it. Now, patient will have difficulty in making urine. Patient will have urine coming in drop by drop. Bladder has to struggle to expel out its urine. So this zone is responsible for the benign disease of the prostate, which we call it as BPH. BPH disease comes from the problem within this transitional zone. So the transitional zone is that zone which immediately surrounds completely around the circumference of the urethra. Now it is being overlapped by this zone, and this zone is called central zone. But before that, this is my central zone. This central zone, practically speaking, has no role, has no value, is not being affected by any of the disease. Beyond that, I have another lobe. This is my peripheral zone. And peripheral zone of the prostate is that zone which is primarily responsible. If pathology occurs in the peripheral zone, most likely it will be the cancer of the prostate. Cancer of the prostate is one of the killer of men, and most of the big names of this world, most of the big leaders, if you see who killed them, what was their cause of death, you'll be surprised to see prostate cancer was their killer. They died of having prostate cancers. Once Newsweek published a full list of those images, those names and their pictures, that all these big leaders of this world, they died because of they were all having prostatic cancer. So prostatic cancer emerged from this layer. That's why those who are affected with prostatic cancer, they will not present with any kind of urinary complaints. When they are having a disease, having a cancer in their prostates, they don't know themselves. But is there something bad is happening to them? Once this cancer has been spreading out of the gland, once it's becoming untreatable, it invades their bones. And now they present with backache. And when we investigate for this backache, then we found, oh, there is a prostate. Tissue is being found in the bones. So now that is a time where you don't have too much treatment, you have limitations. Now the cancer has already spread. And the cancer of the prostate usually present with backaches. And once you investigate it thoroughly, then you can find it. This person is suffering from that. So what is the keywords? 2 keywords. Transitional zone, responsible for BPH. Peripheral zone is responsible for the cancer of the prostate. That's why we are doing a rectal examination, and this rectal examination is very important. No GI examination is complete unless you do a rectal examination. So this rectal examination, if someone has a cancer, this is the only way, easiest way, you do a rectal examination, and if there is a cancer, you can feel because prostate is so deep inside, there is no way you can palpate the prostate. So you have to go through the rectum. Now, there is one very small exercise you have to do yourself. Touch your forehead. I request all of you, touch your forehead. Malik, you don't have forehead? Touch your forehead. You have a feeling? Yes. Now touch your tip of the nose. Is it different?
Yes.
Now touch your earlobe. Is it different?
Yes.
Now, this feeling is the feeling of the cancer of the prostate. Hard, stony hard. This feeling, this firm feeling and enlargement, this is BPH. And this feeling, prostatitis. prostatitis. A big number of people, a big number of youngsters are affected with prostatitis because it is one of the condition which is associated with sexually transmitted disease. And in this disease, those who are affected, their prostate become this soft, it is so hot, it is so tender, and it's so painful. And trust me, prostatitis, it's a disease. If it's occurring to somebody, it takes years to get off. You keep on eating antibiotic like I don't know what, and then there's no relief. So I hope you understand. Now let's see prostate. Yes. Can you speak loud?
If there's an enlargement in the prostate,
Yes.
I know it's anterior to the rectum, so
Yeah, in the anterior wall of the rectum. Don't say anterior. Anterior to the rectum is your bladder.
yeah, anterior wall.
Inside the rectum. Yes.
Okay, so if there's an enlargement, are we going to have difficulty in defecation since it's compressing the...
Yes, you will not have defecation. Usually you will not have. Guys, he has a very valid question. Listen to him. He's asking if someone has an enlarged prostate, will he be having difficulty in defecation unless he has a prostate which has grown super big. You know, when we were all born, our prostate was the size of a chickpea. And when it become problematic, it become the size of a Portugal. And if what he is bringing, if it goes to the size of a grapefruit, then it can cause a disaster. What you're talking. But usually, those who remain under normal condition, those of you, like I'm not saying you, I means people, those males who are always having constipation, chronically constipated people. What happens when the pallets of the feces, Abdul Aziz, when we have passage of the pallets of the feces, these pallets of the feces, they may rub the prostatic tissue when they are passing through the rectum, because the prostate lives in the anterior wall of the rectum, in the lumen of the rectum. So once the feces are passing, not in the lumen but anterior wall of the, so when it's passing down, so it can rub on the surface of the prostate gland. As a result of that, the prostatic fluid will be initiated and someone can have a feeling, or not a feeling, rather you can see some passage of some sticky material which can be seen at the tip of external urethral meatus. So once you are using your restroom for the time of defecation, and if you notice that there is some sticky material which is being felt at the tip of external urethral meatus, that is nothing but the prostatic fluid which has been coming out due to the rub which has been created by the pallets of the feces. They rub against the surface of the prostate and that causes liberation of that fluid, which is the prostatic fluid, and that is being shown up in those situations. So many times you will find the patient, he will come and talk to you, I have some stuff coming out, and then you have to inquire him, do you think you are constipated? How are your bowel habits and how you really encounter? Yes, Maz. Yes,
Doctor, if the prostate gets enlarged, like for example due to a tumor, can it put pressure on the urethra and block it
yes, and your question has value because it usually happens late. It's luck of the person. It's really luck of the person. If it causes compression on the urethra, then the person will come and see a doctor. And if a person will come and see a doctor, doctor investigate it. So if you pick up the cancer of the prostate early, you can save a lot. Like I always give the example of one gentleman, Tom Cruise. He had the cancer of the testes, but he was picked up early and he got the treatment. And now he is surviving. He's a legend. People like to watch his movies and everything. And he had a cancer of prostate and he has a good life. He's enjoying his life. He's earning what we cannot even think. So if we intervene early, we can get rid of any cancer. So what you are saying, if someone is his luck having a cancer in the prostate and if it involves the urethra, now that is a good thing for the well-being of that person if he's being cared by. Brother, what is your question? What do you have?
He asked what's the cancer we took in GI of the pancreas? That's what I asked.
Okay. I thought it's again something new for the prostate. Someone was raising hand somewhere. Yes.
I was just wondering, can the tumor from a prostate cause constipation in a person with a normal diet?
Usually not. Unless it goes super big, then it must. So guys, now just be focused. This slide has little bit overlap. So what we can see, this is a section of the prostate, and there you can see there are numerous ducts, numerous glands within the substance of the prostate, and they all are connected to the urethra through this branching pattern. And this is the urethra, this whitish patch. And these are the prostatic glands. These are the different names, and this is the prostatic urethra, and this is the utricle. And now, these are the views. These are the glands, ejaculatory ducts opening, you can see that, and these are the lobes of the prostate, posterior surface. Now there is a sulcus in between. Now, this green patch indicates the transitional zone. This green circle indicates the transitional zone of the prostate. Now, if the disease is occurring in this zone, so it will be clasping the urethra. So patient will present with urinary symptoms. And if the problem is in this zone, the main area, the peripheral zone, the story is don't get deceived with the central zone, and don't get, by hearing central we think, oh, it's the one who surrounds the prostate. It doesn't surround it completely. So peripheral zone for BPH, and peripheral zone for cancer, and transitional zone for the BPH thing. So this is been shown you here, the area from where we get the cancer. Now, this view, you are looking at, this blue is, number 3 is my transitional zone. Number 2 is my central zone. Number 4 is my fibromuscular zone. And this red thing is my peripheral zone. And you can see that this is the bladder, this is the prostatic urethra, this is the ejaculatory duct, seminal vesicles, and this is the urethra which is going through the prostate. And this is exact, this is showing you 1, 2, 3 and 4 zones of the prostate. Out of these zones, the zone number 1 is for the cancer, and zone number 3 is for BPH. Are we clear? Now, same view with different colors. Now this is an enlarged prostate. And now let's see what happens. Prostate and seminal vesicle. We know these are the structures, these structures we just label them. Let's put prostate here. This is what? Internal urethral sphincter is living here. You can see the sphincter now. Can you see the sphincter? Yes. So now these are the ureteric orifices. Trigone, this is the prostate gland. Are we good with this so far? So now we are good with the seminal vesicle. You can see how ejaculatory duct pierces it, and it's been connected to the prostatic urethra. This word seminal colliculus is another word for saying volumentanum. Now this is the rectum. Are we good so far?
I have a question. Are both sphincters involuntary?
This one involuntary, the external is voluntary. Are we good, guys? Because this is connected to my next slide. So parts of the urethra, just recap. This number 1, pre-prostatic urethra. Remember that, pre-prostatic urethra. Number 2, say it. Prostatic urethra. Number 3, membranous. Number 4, bulbar. Then it has 2 parts, spongy and penile. And I talk about straddle injury. I talk about if you land upon bar of a bicycle, or you land upon a manhole cover. So this is the penile portion, and this is the bulbar portion of the main urethra. And then it lands up with a navicular fossa, and then we have external urethral meatus. Are we good with that? Now, let's see what changes are occurring. This is the main slide of whole prostate. If you understand this, you will understand everything. What happens when the transitional zone is affected? So what are those presentation? What are those anatomical changes? Clinically, we call it prostatism, or we call it LUTS, lower urinary tract symptoms. LUTS or prostatism. These are the words. Old books talk about prostatism. Newer books talk about LUTS, lower urinary tract symptoms. So let's see what happens. This is a normal situation. Now please be attentive here. This is a normal situation. We know these levels. Now this is enlarging. Can you see that? It was not shown before. So this lobe, this part of the prostate is being protruding. So as a result of that, so transitional zone is being protruding. So now it is going up. As a result, what happens? It's enlarging more. So the sphincter is being distorted. Now person become incontinent. He don't have a good control on his urine. He passes urine little bit. It's not that good. So internal urethral sphincter has a problem. First there was a transitional zone has a problem. And number 3, can you see that it becomes narrow because it enlarges? The channel is not that wide. Before it was this wide. Now it becomes narrow. So distortion of the prostatic urethra. Now urine starts staying here. So person after passing urine still have a feeling, still I have some urine left, because this little quantity of urine which is just being trapped in this small puddle, a small puddle of urine, but it is where on the trigone. So it gives false sensation to the brain, oh there is some urine left. So person is keep on going and coming, and he's been sitting for long like, oh I should clear up my bladder because I have to do this and that. But poor him, look, they say women also suffer from prostate. How? Women can also suffer from prostatism. How? Any idea? Yes, Abdulaziz. Woman pregnancy, she has prostate?
No, she has to go to the bathroom.
No, that is UTI, my dear. Women can suffer from prostate.
Maybe from STD?
No. That gives her infection.
Skinny. The organ skinny.
Okay. No, not skinny. Now just think it. Life. Now what happens? Those who have problem with the prostate, it's been said, put their bed in the restroom, because whole night they keep coming, going. It's a disease of old people. You have seen your grands, I know my grands, when they are really old, when they walk, they are so noisy. They use sticks, they stuck with this thing, they turn on lights, they do this and that, and they are visiting the restroom, maybe in the night, 10 times, 15 times, they keep on coming, going. So the old lady, the granny, who's sleeping next on the bed, how much her sleep will be? Will she not be affected? Yes. So this is how she is affected from prostatism. There is no pathology with her, but she's been kept awake. In older age, Muhammad, in older age, there are old grandparents. How weak is their sleep? They go sleep a little bit, then they get awake. So they cannot sleep well. They need pills and all that. If you slept and somebody is bothering you, unless they separate their room, then it's fine. But otherwise she is suffering from, this old man who's been visiting his restroom for whole of his night. Do you think he has completed his sleep? Once he has not completed his sleep, but how he'll be now? Will he be so nice and pleasing to you? He'll become irritable, he's bothered, he's affected, and once he's affected, the whole house is affected. Because the grandfather is affected. Then he affects everyone, where he has his influence. So now, we were talking about, are we good with these changes? 1, 2, 3. So now, what happens next? So correction of residual urine. So even they pass urine, but still, some urine stays in the bladder. Some urine stays in the bladder. Yes, push, nice.
So doctor,
Huh?
so how does prostatism happen in females? It affects. You said how it affects, but it is explain on how.
It's a social effect, my dear. It's not an organic effect. If your wife is in trouble and she leaves your bed out every 10 minutes whole night, next morning, will you have a good sleep?
No.
If your if your kids are coming to your room and turning on and off, on and off lights, what will happen? You have a sound sleep?
No.
If your brother does this, you'll be nicely sitting here, you'll be bothered, you'll be sleeping, wearing a hoodie in the back area.
But are you affected with the disease or?
No, there is no disease to them. This was one of the commercials, one of the logos from a pharmaceutical company. That woman can also be affected by the prostate. How? Because the grandfather is affected. So granny is also affected. Are we good with this? This was just a joke. So guys, are we good with these 4 findings? Do you think are they enough? Are they not enough to disturb someone?
Yes.
Yes. So now, what happens? These people, they have started, sphincter is weak, and all the time they are dribbling urine. And when they are passing urine, urine is not coming with the same jet. Before, they were passing urine, it was going fast. Now, the urine starts flowing on their own foot. If they are standing and passing urine, not in our culture. But, now their urine is falling on their foot. Now they need treatment. Treatment is not desire to someone pee like a horse. The desire of the treatment is someone should pee like a human. So your urine drops should not be falling on your foot. So it should have some projectile. But now with the urine stays here, it starts dribbling down. And that has a name, dribbling of urine. And this has become, sphincter is not working properly, it becomes incompetent. So these 1 to 5 are those which are the situations. Now you can see here how a prostate which is enlarged, how it looks like. This is a real picture. And now, once it is enlarged, there is a bad pressure. It affects my ureters. It affects my kidney. And an end result, if we don't get it, look, this is a normal situation. Normally, the lobes of the prostate far away. And once it is diseased, how narrow they are. So, they don't allow. So, bladder, in compensation, it pushes out. When you do workouts, what happens? What happens to your muscles? When you go to gym and you do workouts, what happens? You develop muscles. You show to your friends. Oh, I have this and that. Now, this bladder developed its muscles. When it developed its muscle, you can see what happens to this lumen. The muscles got separate. The mucous membrane pops out. So many diverticulars can be made. So now, this is a prostate where you can see how much is enlarging. This is the pocket where urine can be stored, can be staying all the time, day and night. Bothering a lot.
So doctor, can lead to kidney failure?
Yeah, ultimate thing is azotemia. End of the story. Someone died, chronic renal failure. So now here you can see the effects of an enlarged prostate. Within the prostate it is enlarged and there is a disaster. Yes?
Doctor, can't we just cut off the entire prostate?
Huh?
Can't we just cut off?
Yeah, we can. Now this is the cancer of the prostate and you can see the cancer has spread to the rectum, to everything, and then it will be going to the bones also. So this is a picture of the cancer of the prostate. Now, quick recap. How we can remove prostate? Old days, there were so many approaches. Nowadays, only one approach, the best approach. If a unit does 2000 surgeries in 6 months, out of this 2000, 3 or 4 open procedure, rest all are endoscopic thing. We insert the whole instrument from the urethra, we resect out, we take the chips out, prostate, we make an enough channel, person can void nicely, you give them 10 good years. If you give 10 good years, someone who's 80-year-old, what does he expect more? How much people live normally? Tell me.
70.
70. So if a 70 gets 10 year more relief, if need arise, you can redo it after 10 years. But the mass what you are asking is not necessary to kill the whole prostate, you can give a nice place. So you can do, person can survive. So now, these are different approaches. So just for our knowledge, some of them are historical. Only what is in most used is this one, number 3, transurethral. Now, this was very old-fashioned thing. From the bladder, and this surgery was not done with a knife, it was always done with a finger. So you are just removing the whole prostate. This is another approach. And this is what, which is the best, which is, this practice, this is still this practice is 1000-year-old. This is not new. But over 1000 years, it has changed from different units. So this is what you see on the monitor. You're chopping it away and you're just taking slice by slice, shrimps you're making, and then you just dissect out the whole prostate, and then you have a nice channel, everything is happened. Look at it. You are pushing it and you are resecting it. Are we clear? So this is the transurethral resection of the prostate. And then you can see the different ways before your surgery, after your surgery. Do we need to remove the whole prostate? No, I think it's enough after TURP. And this is how we do the TURP. I think I should stop here. Urethra, I'll cover it later, don't worry for that. But the main stuff we have done. Any question? So guys, my next 2 sessions, one will be about urolithiasis. How the stones are formed in whole of the urinary tract and what we do with them. This session is connected. I will bring some video clips, some live situation where you can see yourself how these procedures are occurring, and I'll try to bring even a picture of video of suprapubic catheterization and also some other things that will be helpful, and it will be followed by clinical anatomy. Thank you very much.